We must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Hey, everybody, and thanks for listening to another episode of the Healthcare Education Transformation Podcast. This is Brandon speaking. And before we get to our interview with Dr. Sahrmann, I just wanted to give a brief disclaimer, as Stephanie and I had actually recorded this episode live and in person at APTA's next conference in June 2018. And unfortunately, while we were doing it, the audio did pick up a little bit of some background noise that was unable to be edited out. So we did have some audio issues there, and the audio quality is not 100% perfect, so bear with us. So we apologize for the inconvenience. But without further ado, here is our episode with Shirley Sahrmann.
Hi, everyone, and welcome to the Healthcare Education Transformation Podcast. My name is Stephanie Wyrock, and I'm one of your co-hosts. I'm joined by my other co-host, Brandon Poen. We're here live at APTA Next, and we're joined by one of my favorite people in physical therapy, Dr. Shirley Sahrmann, who was a mentor to me when I was at Washington University in St. Louis as a student. And I'm just so honored to have you here on our podcast today, Shirley.
Well, I feel like the tables have been turned, and you're now my mentor. You're setting off in ways that 21 or whatever it is that you are, I didn't get to until I was 75. I don't know who's mentoring who anymore, Stephanie.
Shirley's referring to the Oxford debate that I'll be participating in at a young age, and she just did it a couple of years ago. And,
Yes.
And so we were joking around about that. Well, Shirley, for people that maybe aren't familiar with you, can you tell us a little bit about yourself and what got you to where you are today?
Just staying alive. Well, we have to do the short version because it's like 80 years worth of conversation. So I kind of say that at the time I started off, I was growing up during the polio era, and it seemed very appealing that you would help these little paralyzed kids be able to be active, because I was very physically active when I was growing up. In fact, the fears were at that time that I would never grow up. I'd still be playing games. And now that's why I got to grow up, because I played games.
The irony.
Yes, the irony of it all is that what was supposed to go away happily didn't go away. And so I sort of started in polio started in the physical therapy as this initial interest of mine. And it was also a time in which I think I could easily say careers for women were somewhat limited. Women didn't think about going to medical school at that particular stage. And not that I would have had that kind of ambition as it was. In fact, I still wonder about why I went to college, since my parents didn't even go to high school. And anyway, it was a very small world, but I got to Washington University's program in physical therapy, and it was a very transitional time, because by the time I was in physical therapy school, the vaccine had come out, and so the polio patient was going away. And in came the neurological patient. And believe it or not, they were just saving the lives of people that had head injuries, spinal cord injuries. In fact, any male over 6 foot that was rear-ended became quadriplegic in those days, because there were no seat belts, there were no headrest, and so it was, here they come. So we had a lot of really big guys, and strokes were common in 50-year-olds because hypertension wasn't being controlled at the time. And so I started right away in my early career caught between the treatment of the polio patient, a now well understood lower motor problem, and the neurological patient, the upper motor neuron lesion. And the conflict was the things that you did with the polio patients you weren't supposed to do with the neurological patient because it would make their condition worse. But we didn't know what you should do. And so that right away set a whole career about, I really wonder what I'm supposed to do here because I don't understand these problems. In some ways, the polio was easier because you kind of understood what it was. And you weren't supposed to figure out anything anyway. You were just supposed to do what the doctor said. I wish it had taken more years before I found out that the doctor didn't know what to say either, but it took me a while to figure out. So anyway, I think in some ways that and sort of the growing up thing of I always wanted to understand why I was doing something, what it was about. And this transition time just also set a direction for me of trying to understand what in the world I was doing. And that's sort of how I got started. And then, being a fast learner, 9 years later, I knew I didn't know what I was doing. So one of the, I don't know, what do you call it, magic or blessed parts of my life is I've always been in the right place at the right time. It was timing that was so advantageous for me, that timing. And then another timing was I decided, since I didn't know what I was doing, I needed to go to graduate school. And they were just starting the neurobiology PhD at Washington University. They didn't know what they were doing. And they just said to me, go find a mentor. They didn't look at my academic credentials, which weren't. This is totally true. And the reason why I say about timing, well, number one, they were just starting the program. They didn't have their act together at all. I just went to the guy that was head of it, and I said, I want to go to graduate school. He said, well, find a mentor. Well, it turns out my fourth cousin, 16 years old, had a stroke. And I was his therapist. And one of the most, how should you say it, argumentative neurologist was his neurologist. And we got in an argument about how this boy should be managed. And happily, he had a really good outcome. Now I know it was not because of me, but whatever forces take care of us. And the neurologist so loved that we argued about this, and that I was doing something. And he had gone to a big conference where he heard all these physical therapy types of interventions, and he just got up and said, black magic, witchcraft, crap. And so when I go beep out, and I decided that he would be a good mentor because he was interested in the same thing I was, which was the upper motor neuron syndrome. And I said, Dr. Landau, I would really like to get in the PhD program. And he said, well, somebody's got to straighten you physical therapist out. I'm telling you the total truth. So he said, okay, I'll take you on as a PhD student. Well, you know, so here I am, 9 years later, in class with these medical students. The medical students at Washington University are the #1 students in the country. I mean, Harvard, they are the highest ranked students in the country. I'm sitting in biochemistry, and they're talking about esters and ethyls, and I'm thinking of all the girls I went to school with. I mean, this is totally true. I love it. Well, the only thing I got right on that exam was my name. It was only because they asked me early. Oh, I mean, it was awful. And so they looked at my record and was like, oh my gosh. You know, in those days, actually, when you went to PT school was the last 2 years of college. It was a BS degree. And they didn't even count that as academic credit for people to apply to graduate school because it was supposed to be professional education, even though some of it had been taught by the scientists in the medical school. So anyway, my Bill Landau. Oh, and the other fortuitous thing is his major lab assistant, co-researcher, head of the EMG lab, was a physical therapist who had gotten her degree there but never practiced, immediately started working in neurology. So she was sympathetic to me. He was sympathetic to me. And so they let me go back and take some courses on the main campus to get up to snuff and eke my way through the rest of the PhD program, which took a mere 7 years. And then they were kind enough to hire me back. And my job was coordinator of the basic sciences for OT and PT. And again, the fortuitous timing and people and all the rest. And in fact, the only time I wasn't at Washington University, to backtrack a minute, after I graduated, I went 3/4 of a mile away. I was able to find it all by myself. And then that's when, and that was I graduated in 1958, where your grandparents were born. And in 1959, again, because of a Hill-Burton Act. It was an act to build rehab centers. Money was put forward, so none of these places were shy about figuring out how to get more money, so they sort of built this sort of rehab center. And Washington University took it over from the hospital, the physical therapy service, and so made it more academic. And I was recruited back to be part of that staff. And so that immediately, and I knew I wanted to be in a place that was academic and would ask questions, and have smart little students coming along and saying, "What are you doing?" And I'm saying, "I don't know." I'll figure it out in 20 or 30 years, so call me later. So anyway, I knew that I wanted to be someplace because I was kind of intellectually lazy, and this would be, this is the truth. I started teaching in 2nd grade. I mean, I'd be pulled out of class to help teach kids. And that was the way I was motivated to learn things and to be educated and educate. I mean, you know yourself that there's nothing like teaching something to learn it. Mm-hmm. And so that's kind of the background of why I was always questioning what was going on, why I wanted to be in an educational setting, and why being in a premier setting like Washington University with all of these people was an ideal place to be. And it was a transition time because actually we became part of the Department of Preventive Medicine, which has now gone away because it was so far ahead of its time. They were worried about nutrition. They were worried about prevention and exercise. In fact, one of the key figures in that program was a physician by the name of John Halsey. And John Halsey was the one that determined exactly what the mechanisms were for the training effects. He discovered the increase in mitochondria. He got sort of the Olympic comparable medal comparable to the Nobel Prize for his work in exercise physiology. So it was just a really great environment, and I was just so lucky to be a part of it.
I really appreciate some of that historical perspective that you bring about, saying that there weren't a lot of professions for women. You just kind of did what you thought was right for women at the time. One of the things that I've always admired about you, Shirley, is that you're very outspoken and you're not afraid to voice your opinion. One of the conversations that people have been having on social media and in the PT world is that a lot of times women suffer from imposter syndrome. They have a hard time voicing their opinion because of how they're going to be looked at, or sometimes they just don't feel empowered because a lot of these panels that we see are sometimes filled with a lot of men. What's your advice to young women on letting their voice be heard and building that confidence to be able to say, like, this is my opinion, here's how I feel about it, and not be afraid to come forward?
It's another one of those kind of fortunate things. My whole upbringing was not gender specific. My father wouldn't let me drive until I could repair the car. I'm serious. I had to be able to do new points, plugs, the whole 9 yards. My brother had to do dishes. I mean, so we didn't have like boys do this and girls do that, except maybe when I went to my grandmother's. So I've never felt myself that I had to not participate or not say what I thought. And then I was so lucky because this neurologist that I was telling you about, he was actually head of the ACLU in St. Louis. And he wasn't, he got me to tenure, and I was one of 9 women at the university with tenure, and I didn't deserve it. I'm not being falsely modest here. I did not have the research record. So I've always been very supportive, and I wasn't in a business world where, you were looked down on. There was this general thing. In the old days, you could not get off of an elevator in front of the doctor. The doctor had to get out first. There was that whole thing. I never paid a whole lot of attention to that sort of thing. I didn't bust my way out of the elevator, or you couldn't wear slacks into the cafeteria because you were a woman. But those things just didn't bother me in the face of everything else I thought was of value. So I never suffered in particular, and I just always thought that having my say was, kind of nice. And I always knew that here's my overriding philosophy forever, is I really believe the good things persevere and the nonsense goes away. So I'm not worried about people jumping on the bandwagon. Like, I've been pushing this movement system thing for 30 years. And I always thought if it's worthwhile, it'll have its day. If it's not, it ought to get pushed aside like everything else that isn't worthwhile.
So going off that, you bring up the movement system.
Yeah.
So the visions there, the APTA now has been crafting their message around the movement system. And when the movement system came out, and I was coming up through PT school, it was so cool to come from a place where we had already been talking about that. That's second nature to me. Like, the thought of not having a movement system is a foreign concept.
Right.
It's taken a long time for everybody to get on board with that, and there are still people that aren't on board with the movement system.
Yeah.
Tell us about your journey through that and how you've been able to help the APTA kind of realize this vision, and where you see the vision going from here on out.
Well, So part of why it wasn't just me, and I wrote a big article, called "Physical Therapy," the movement system, the identity of physical therapy, because I think what I'm good at is recognizing a good idea, and they always say, when you're little, you're stubborn and obstinate, but when you're older, you're persevering and tenacious. Yeah. Well, I was stubborn. And so, I kind of stubbornly held on to something. And all this idea about a movement system or something like that was sort of twofold, because after one of the leaders in the profession, who was our program director, had been our program director, his name was Steve Rose, he was really foresighted. And he was the one that talked about diagnosis, classification, et cetera. And because I was half-time in neurology, I actually, believe it or not, trained monkeys and recorded from their motor cortex for 19 years, trying to work on this upper motor neuron syndrome issue. And Steve came and was director of the program, and he had the idea about classification. Well, being in neurology, where that's all they do is classify patients, get a diagnosis, and figure out what to do with them. Okay. So that was one end of it. We had this big conference after Steve died, and we threw about ideas about movement science, about a movement system as such. And I kind of held on to that, and that sort of made sense to me. And then happily being at Washington University with all those smart colleagues that we have, all of them, how great they are. We've all been together 50, 30, 40 years. It's been still pushing back the frontiers of ignorance, seriously, still wanting to be learning things, not resting on our laurels because we've done the same thing. Okay. So it was that aspect, and it just, the more we talked about it, the more we hashed it over, the more sense it made. And then, quite honestly, I had put together this little talk for our 75th anniversary,
which was a great talk, by the way.
Well, the reason why I'm bringing it up now, because to answer your question, is that what's really been characteristic of physical therapy, and actually most health professions, is that when money becomes available, things go up. When money gets curtailed, things go down. And so the rise and fall of physical therapy has been related to our income-producing capabilities. And then one of the big blows, when When Medicare came in, we had to get assistance because we didn't have enough services because everybody was being paid. And we did every modality there was because you got paid for every modality that there was. So we were big income producers. That was nice. DRGs came in, jobs went away because now they were cutting back, just didn't get paid that much. Okay, goes on and on. In 1997, they did the Balanced Budget Act, and they took $30 billion out of Medicare. Jobs went away, a cap came in, et cetera, et cetera. Well, it's going to happen again. So I'm very concerned about the future and reimbursement because healthcare costs are out of control. And I consider us quality of life people, not quantity of life people, even though we know that's really not quite true. But if you're going to get rid of something, it's not going to be the cardiologist.
Right.
Okay. So what does that mean to me? It means to me that also, this is my other big cause celebre, is that if you're a therapist, people think somebody else figured out the problem and you deliver up the care. So you have this disadvantage of nobody's looking to you to figure out the problem. They're figuring out you on just helping them recover from the problem. So, and all the people that have the greatest respect are those that are in charge of the system of the body. Therefore, the movement system, defining it as a body system who needs an expert. And in fact, and always my analogies is with the dental profession and the oral cavity. You only need your teeth to speak and eat, and yet we go to a dentist twice a year to make sure we're brushing our teeth. And that's all we do with them. And we spend thousands of dollars to make them straight, and you can barely see them. I'm serious. Here's our whole body hanging out there. We need it for everything, and no expert is making sure that you're using it right, that you're doing all the right things, et cetera, et cetera. So it's like, well, this is so reasonable. What's the problem? So I just kept talking about it because I'm like perseverant. And I'm so uncreative, I can't think of other things to talk about. So I just carry on, and then the more I carry on and hear comments, the more I refine the ideas and then get more smart people on board to help me think it out and recognize the implications. And it's really not what I did at the APTA, it's like people like yourself. And actually, Karen Donahue was a major player, was one of our graduates in Arizona. And when they were doing the vision statement, she said, we need to put in here the movement system. It wasn't me at all. So it's other people who, again, have time to weigh the ideas, to figure out whether they have value, how they should be modified or what. And they're the ones that bring it forth. I'm a big believer that you can't just go from top down and make a rule, but you got to have the grassroots up supporting you, and hopefully we all meet somewhere in the middle on this sort of issue. So that's why I see it as the way to give physical therapy an identity. I think put us in charge of a body system, which is how you claim expertise. And it's a great one because you have to shape up how it develops, not just find out whether there's a disease there or not. And movement covers all levels of the organism. I always like that whether it's synaptic transmitter or insulin going in membranes and cells, it's movement. It's all about movement. So there are no limits, basically. So you've got everything. And I don't understand why we're just not running full steam ahead and see this as the way that gives us the basis for what physical therapy is about.
Why, kind of with you going through your thoughts on where you think the profession and stuff will go, mentioning again the fluctuating reimbursement, the ability.
You gotta have a different practice model.
Right. Why do you feel like, in your personal opinion, why do you feel like this is not happening? Or why are we not going the way we should be?
Well, I think we're going. I mean, we're finally going in that way. I think it's hard. It's hard for people to change what they've been doing for a long time. They're not sure what the implications are. But we were just in a session, and Stephanie was there too. And one of our big problems in physical therapy is the variability in practice. There is no. I always think my marker is, if a surgeon operates, they fill out 2 pages of documentation. We figure out 12 because nobody knows what we're doing. nothing common about it. And part of it is because we don't have diagnostic categories. I tell everybody, I feel guilty about helping students become doctors because they're so bright. I mean, the only thing I had on them going in the classroom is I'd been there a lot of times. I was so old. They were afraid, to knock me out. But so here we got these incredibly bright people. They go to school for 7 years. They owe $100,000. And nobody looks at me any differently than me with my BS degree. And that's the hard facts. That's the hard facts. And why? We're doctors, but what does a person go to a doctor for? A diagnosis. What if doctors understood that these movement diagnoses will explain numbers of their things instead of we're trying to be mini doctors, which we're not being, or we're just some purveyor of a modality. I love saying to people, physicians treat symptoms and consequences. We could treat cause. Do you realize how big that is? It's hard to change tradition. It's hard for programs to revamp all of their curriculum. They don't know what they're going to revamp it to because there's no agreement. We're following a pathoanatomical model, a pathophysiological model instead of a kinesiopathologic model or a pathokinesiologic model. Do you understand? Now, I do believe that even other health professions that are related to movement could jump on the same bandwagon in their own particular ways, because it's another system of the body, and we've been criticized because it's not a basic system like the musculoskeletal or the endocrine or the cardiopulmonary, or the cardiovascular, etc. But immunology is the immune system is a system of systems. The metabolic system is a system of systems. They use every other physiological system as part of their focus, part of their understanding. Do you see what I mean? So a reaction to I'm creating, that we're suggesting there's a whole new system of the body, but we're not. We're suggesting a new focus for a physiological phenomena that's incredibly important. And so I think it's just hard to change tradition. That's right. Australia had the first direct access laws because they were a new country and they didn't have tradition. Europe was the last to get baccalaureate level education. Even in those countries, even in Italy now, if you become a physical therapist, you are not qualified to go on to PhD studies because you're educated at a technical level. So the longer something's been in place, the harder it is to change. That's why I want to make a name change too, because I think it's really important to get out of the therapy context.
And what would that name be?
Well,
you could
well, that's another joke. I have been through several iterations. My first one was Motician, but they thought it was too close to Mortician. And that all movement stops then, so we weren't too interested in that one. Right now, I just like putting something out there for people to play with. I think something like a moveologist. And because cardiologist, ophthalmologist, neurologist, it's all study of. And so in the ideal world, if it wasn't already used for so many things, kinesiologists would sort of be it, but it can't be because it's considered a basic science, and there actually are people that call themselves professional kinesiologists. And so since we're really talking about movement, that's my best thought now. Again, I'm not committed to that. I just believe every passing day that climbing out, see, like speech did it. They changed from speech therapist to speech and language pathologist. I have a friend in assisted living, and they just called in a speech pathologist to see why she's choking. Now, in the days of old, you would have gone to an otolaryngologist, but no, they just got the speech person to come out. So you can do that, but they're not going to call unless the doctor says a physical therapist. Do you see what I mean? And by not generating diagnosis, we're not living up to our big role. Plus, we can't make practice at all like what would medicine be like? And I'm sure your husband says this as a pathologist, but one of my medical friends, a resident in radiology now, says, we don't even understand half of the diagnosis we make. We don't understand the underlying things. Never when I was growing up would rheumatoid arthritis and multiple sclerosis be put in the same context? It is now because you're autoimmune diseases, do you know what I mean? So you have to have some start on commonality, and then you keep looking at it and breaking it apart to refine what's going on underneath or to understand better treatments. But you can't when everybody's making it up as they go along. There's also no such thing as a common exam. People don't. If somebody comes in with back pain, well, with this patient I may do this, another patient I may do that. Well, you can't do that. You can't see patterns. Because the big difference between a novice and an expert is pattern recognition. Well, there's never going to be any patterns evident if you're doing something different with every patient that comes in. So to me, those are the fatal flaws, that the profession has not fleshed out the things that are necessary if you're in charge of a system of the body, called diagnosis, called examination, and made that consistent.
I appreciate the comment that you made about it's hard to change tradition. Another big topic that's been going around these conferences as I've attended them, is that that's one thing that millennials are not so into. They want to change fast, but change takes time. What type of recommendations would you make to educators, to program directors about kind of working towards some of these common goals?
I mean, the recommendations are all these things we're just talking about right now. Hopefully, the APTA is trying to pursue things. I think the biggest challenge is all of this stuff coming down on you to do, whether it's your interests of social change or healthcare policy or whatever. But I keep trying to make the point that all the little avenues or distractors of what it is we could do have to have some kind of common focus. If physicians didn't have their common focus on what it was, they couldn't be involved in healthcare policy unless they knew what it was they were going to contribute. I don't think we have enough commonality in what it is I know we could contribute. It doesn't mean there can't be variations on the theme, but you've got to have some constancy in that theme, and we don't have that as I see it now. So I think it's a willingness to buy in that we're responsible for a body system, that we should be experts in movement analysis and take it in whatever avenue you want to go, but this is what I have to offer. I think that, I think the bottom line for us could be that the biggest sell in the world, if I'm half right, is that we could be the people that slow down the onset of osteoarthritis. I'm not going to get rid of it, but I'd rather get it at 80 than at 50. And I think we are the people that could do this, because that's a disease that's related to impaired movement and a process. I don't even think it's truly a disease as such. It's not a systemic kind of thing. So, but until that's clear about what we're about, because again, if you probably could interview 10 more people here and they would tell you something different. In fact, it's another story out of my past. When I was president of the Missouri chapter, where the APTA wanted us to be able to speak to the public, so they actually hired an expert to come in and talk to the chapter presidents and get them geared up to be able to be interviewed, etc. I'll never forget this because it was one of my life-changing events. So the guy's sitting to interview us, and another chapter president is sitting next to me, and the interviewer says to him, "So what is physical therapy?" Well, this guy got the blankest look on his face. He hemmed, he hawed, he went, oh, ah, ooh, ah. And I'm looking at him in just like this horrible facial expressions, which they replayed. And so the interviewer said, Shirley, after you looked at him all those ways you did, there's no way anything he said would have any credibility. What am I thinking? I'm glad they didn't ask me. It wasn't like I'm sitting there with the answer. I'm like, oh my God, what would I say? But that was life-changing to me, because I thought, here I am. I'm going to say, will I drag paralyzed people down the hall? Or I help them get out of bed? Or I walk them to the bathroom and stand there and chat with them trying to do something? I'm serious. I thought, what would I say I am? Somebody who follows orders good? So that put me on this big pursuit, and that's part of also what led to the movement system, along listening to other people and what makes sense, and that how do we describe ourselves? What's so clear is that change takes time, but that time is getting shorter and shorter every passing year. I mean, This perspective on time, I mean, all you have to do is think back to early presidents and how much information they had or didn't have compared to what we have now. I mean, nobody can go out a front door without everybody reading about it. I'm serious. And then it hits social media, and my God. I mean, now thousands of people have that same information where it would take a year for somebody to have that kind of information, even 50 years ago. So change is taking place, and I think that it's always the balance between, is the change really good? Is the change not so good? When do you throw the baby out with the bathwater, or how much do they need to be cleaned up before they're put out to dry? And I think that's the part that's scary for the old people, and you young people don't know enough to be scared. So change isn't always good.
Yeah.
Education is going to change, and in some ways I'm a little surprised that that younger people still want textbooks instead of just everything electronic. I know. Now, the people coming along now are getting more used to the electronic version, but I'm telling you, just even 2-3 years ago, people didn't want to have just the electronic version of things. So, and all this stuff about flipped classrooms, active learning rather than passive learning, it's not as efficient. It's harder for faculty to construct. How do you keep track of change? In some ways it should be easier, but that's all like a lot more work that has to be done. I think people sometimes, I'm kind of laughing because I know many students that can't wait to finish school so I can go out and learn something. And you're like, oh yeah, really? And then the sad part is every study in the world has shown that students practice like their clinicals and not like their educational experience. So I don't think it's, and like just now the conversations that took place, that if we have our own students, when we turned them out, they would go places and people didn't let them practice like they were turned out. Are they not active resistant? Don't you do that Washington U stuff? And then if they get a job, well, you don't have 45 minutes for an exam, you have 20 minutes, and then you just hurry up and send them out for their exercises out in the gym with everybody else. I mean, so there are these financial pressures. Schools also operate by financial pressures. More students, more money. Fewer faculty, more money. I mean, bottom line's big driver for everything. And then it's figuring out, and that's where I see our practice model has to change. Our educational model is going to have to change. So the business model is changing. Now, getting all those things to work together at the right time. But none of these questions that we're talking about are on the licensure acts. If we're moving towards a movement system, where's all that stuff about that? It's not on there. The criteria for clinical instructors is not incorporated into that. So yes. Now, how long does it take to change the licensure exams?
Kind of what you want to know.
Yeah, well, I mean, I'm just saying, those are the things the students say, well, I still need to know this to pass that licensure exam. But there was a good comment in our session on Thursday morning that learning all this other stuff doesn't compromise your ability. In fact, the school had a 100% pass rate. So it doesn't mean they don't know the old stuff. It's just not reinforced as important on in those particular documents, etc. So that's why change is slower to be implemented, why people are taking some steps backward because they don't see it modeled. It doesn't fit in with a good business model. Even though, in my mind, see, I am so worried that I think that physical therapy should be like operating independently. That's why I use the dental model. They said it today at the Rothstein thing, that we don't go see the doctor first and get the MRI and get the referral. We should be freed up of all of those. We're just another widget. You know, that's why I always use, what is the biggest amount of money you would spend on going to see a dentist? Let's say $3,000. You start down a medical line of care, $3,000 is just getting you initiated to what you're going to do next. You know what I mean? So we're part of that little piece of a very expensive pie. Instead of, here's my pie, and this is all I'm ever going to cost you. And if our model was to see a lot of different people infrequently instead of a few people frequently, which is the current model, it would be a totally different story. How is that hard to change? Hard to change because the money's coming in this way, not the other way. You see what I mean? So no matter what we educate people to do, they are not reinforced when they go to get a job. They are not reinforced in the documents that require licensure, specialization, etc. So that slows it down. That's a long answer.
No, but it's good because I think honestly, I mean that's really truthful. I mean, because you can change one avenue of it, but if you don't change the whole thing at a level, you're not going to get that carryover to that level.
Yeah,
that is
it's really
needed.
hard. And I know I've talked to younger people, and I think it's very easy for me to get younger people thinking all this makes great sense, but then they go out to the real world and it's not happening, so they lose their enthusiasm, they lose their direction. And
Yeah. Well, I must admit, it's been quite an amazing interview today. Just hearing all this stuff, hearing your background, going through your thoughts on everything. I've really learned a lot from this talk. So thank
Finley
you.
took so many minutes. I had to go to school for 3 years to hear.
I know.
I know, right? But we usually like to ask this question at the end, and I realize that this question you probably have touched on throughout our whole discussion here. So if you'd like to maybe add another piece on it that we haven't talked about, or if you'd like to reiterate a point that you said before, that's totally fine. So the question is, if you could change one aspect of DPT education, which aspect would you change, and how would you change it?
I would do, I have said it before, and you'll hear me saying 5 million more times before I leave this earth, is that I would change it so that it's a diagnosis-driven education. To me, it's ridiculous to say we do clinical reasoning and that we go through every step on the way and reason out what the problem is. That is so inefficient. You don't know where you're going, you don't know what you're doing. And if you, like everything, what is a diagnosis? It's explaining a pattern. And so you explain that pattern rather than thinking somebody's going to sit there and figure it out, because we're the people, not just like the physician who just has to figure out what's wrong and where to send them radiology or where to send their blood to. We have to give the treatment. Then we have to do our 12 pages of documentation because nobody knows what we're doing. No, you know this is totally true.
Yeah.
So it's changing. Why does the physician only have to fill out? They have a lot. They complain now with what they have to do, but they have scribes too. Anyway, but they have to fill out a lot less because what does the diagnosis do? It says this is what goes with this diagnosis. And it doesn't mean it's going to be carved in stone. It's just the first pass. We don't make these first passes. In many ways, it's safe because nobody can say we're doing the wrong thing because there is no right thing. It's well defined, even though there's kind of indications in the literature, but we can't depend on the literature because it's all new. It's not directed to us. And so I always say, yes, today's evidence is tomorrow's tragedy. Having been through that a little bit personally. Like I was on hormone replacement therapy until I got something in my boob. I've had the patients that were on the phosphates and then their jaws went bad and their bones broke. But that was the evidence at the time. So I would like to change it, particularly for physical therapy. And I think and then the flip side, not only would it give some commonality to what we're about, but on the flip side, it would also let other people know there are these conditions out there, which we're not doing. But if we play mini physician, we're not telling them how movement causes problems, rather than just a problem causes a bad movement. And that's what they think, and that it's not that tricky. And if you can just count to 10 without getting bored, that's all that's necessary.
Well, thank you so much, Shirley, for joining us today. I love talking to you. Every time I come to a conference, I always hope that I get to see you so I can come up to you.
Because I think you're going to be too important. I want to say, please, Madam President, can I have an appointment with you? I know it.
That is a very humbling statement coming from you. So thank you so much, Shirley. And if people want to contact you, how can they reach out to you on, say, social media or the internet?
I just do not do social media. I mean, my life is so exciting. And I do all these bad things, and if everybody found out about it, it would really be. No, I think it's like straightforward email.
And what email can people reach you at?
Well, they can reach me at my standard email, which is actually a pass-through, but it's Sahrmann, my last name with 2 N's, s@wustl.edu. I mean, it's that easy.
And I'm sure that if you need to go on, we'll have that posted in the show notes, but we'll also you can go on Google and look Shirley up. I'm sure you'll be able to find her email there as well. Well, thank you, Shirley. We appreciate you coming on today, and we look forward to seeing if these visions that you have actually come to fruition.
Yeah, I hope they're not hallucinations. I'm off my medication, so.
Oh, man. Shirley Sahrmann at her finest.
Oh, man.
No, this is standard.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available in our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.